Lesson number 145, tumors of the gallbladder and extrahepatic biliary tree. Just four major groups of tumors we need to talk about in this question. It should be quite straightforward. So first, benign tumors of the gallbladder. The main thing you need to know for these tumors is that they are very rare, and so there's really not much to talk about with respect to these tumors. You can name a few of them just to get yourself some brownie points. The first one is a cholecystadenoma, which by definition simply just means it's an epithelial benign neoplasia that arises from the epithelium of the gallbladder. And then a few other types can include a papilloma, which again is also an epithelial benign neoplasia, but it takes the form of a papillary frond. And then you've got a fibroma, lipoma, hemangioma, the soft tissue tumors really. And that's pretty much about it really as far as benign tumors of the gallbladder goes. The more important ones are the malignant tumors of the gallbladder, and the major one we need to talk about is a gallbladder adenocarcinoma. And so, by definition, a gallbladder adenocarcinoma basically means that this is an epithelial malignant neoplasia that arises from the epithelium of the gallbladder. And then we need to talk a bit about its features, a bit about its characteristics, prognosis, all of that good stuff. So as far as features goes, this is an aggressive cancer, and by being an aggressive cancer, one important parameter that you can mention is that this cancer has an overall 5-year survival rate. You don't need to remember the number exactly as such obviously, but just for your knowledge, a 5-year survival rate as of at least 2023 when I gave the exam of less than 10%. Its female to male ratio sits at a 3:1. It has relatively very poor prognosis, and it metastasizes to lymph nodes. So it's got spread through lymph nodes, and it also metastasizes into the peritoneum, right? And so now then the other thing we need to talk about is the pathophysiology behind the formation of these tumors before we discuss its morphology. And so basically this cancer, this adenocarcinoma, can be seen in patients who have long-standing cholestasis and cholelithiasis. And what this basically does is that when you have a gallbladder shown in air and a continuous inflammatory process going on in the form of cholecystitis, for example, we'll discuss a few of the other risk factors as well. But with long-standing inflammatory processes and inflammation going on as a whole, what basically happens is that you have a metaplasia of the gallbladder wall. And I hope you guys remember what metaplasia is. By definition, is basically when you have replacement of one differentiated somatic cell type with another fully differentiated somatic cell type in the same tissue. And histologically, it has been observed that the two most common types of metaplastic changes that are associated with the gallbladder wall is the intestinal type and the pseudopyloric type. And then this this metaplasia then it follows the routine epithelial dysplasia and carcinoma in situ and then carcinoma progression. So then we move to epithelial dysplasia, which when it becomes full thickness is carcinoma in situ. And then normally the time period that has been indicated in this progression from carcinoma in situ to an advanced gallbladder carcinoma is about 15 years, give or take. And so in 15 years we see that the patient goes from epithelial dysplasia and carcinoma in situ specifically to an advanced gallbladder carcinoma. There are other risk factors that are associated with gallbladder cancer as well, gallbladder adenocarcinoma, and this includes obesity, recurrent infections, a porcelain gallbladder rather, that we discussed in chronic cholecystitis. It can also be associated with pancreatic plus biliary maljunctions, and also seen in association with primary sclerosing cholangitis. So coming to the morphology, we will see that a gallbladder adenocarcinoma is firstly most commonly seen in the fundus of the gallbladder. So that's right here, the fundus. Then the second most common zone is the body, and then third most common predilection zone is the neck of the gallbladder. So it goes in order of fundus, higher chances of developing an adenocarcinoma in the fundus, then the body, and then the neck. And then we need to talk about the morphologic presentation of an adenocarcinoma. Two types: you can have an infiltrating type or you can have an exophytic type. So I will draw in what an infiltrative type would look like very roughly, and just talk about its morphology, describe its morphology a bit. And so the infiltrating type will present as diffuse thickening, an irregular area of diffuse thickening, and indurations of the wall. These indurations may also progress to ulcerations that invade the wall. And then the second type is the exophytic type, in which case you have an irregular growth that occurs into the lumen. So irregular, protruding intraluminal growth. And as far as the morphology goes, when you look at the cut surface of these tumors, you will see that these can be either whitish tan or they can be yellow on the cut surface. And that is pretty much it for gallbladder adenocarcinoma. Now moving on to the adenocarcinoma of the ampulla of Waiter. Now the ampulla of Waiter, as we know, is the junction of duodenal and pancreatobiliary mucosa, like two types of mucosas. And so effectively you can end up having a very heterogeneous group of malignancies at this site. And so there are majorly 4 types of ampullary adenocarcinomas that have been recognized, 4 subtypes. I've only drawn in 3 pictures here, and we'll understand why in just a bit. But 4 subtypes, and what's important to know is that these subtypes, all of them in common, have regional lymph node metastasis, and they can end up causing obstructive jaundice. And so coming to the morphology, first one that we're going to talk about is the periampullary carcinoma, and the name low-key gives away what the presentation is of this tumor. And what basically happens is that this type of periampullary carcinoma presents as an exophytic tumor. So I will draw a loose exophytic mass that is commonly found. So once again, exophytic mass, and this arises from the duodenal surface of the ampulla, and ends up engulfing, so just another edit, it ends up engulfing the orifice. And so that's how this type presents. Second type is an intraampullary carcinoma. And this is basically a mucosa covered bulge that arises from the intraampullary tubular. It's basically called an intraampullary papillary tubular neoplasm. Don't really get too bogged down going to the name. Just remember that these normally present as a mucosal bulge, so a bulge in the mucosa. So mucosal bulge that is seen within the ampulla, and that's about it. Third type is, by definition, or rather by name, the ampullary ductal carcinoma, and this will present as small. Of course, these are not to scale and not exactly accurate drawings, but just to give you the idea so you can remember, is that these present as concentric elevations with ulcerating. So I'll just draw in a little ulcerating diagram of sorts, whatever you want to think of it. But it's got concentric elevation with these ulcerating retractions that are occurring at the level around the orifice. So 2 of them present around the orifice, 1 within the orifice itself, and these are the 3 major types. The 4th type is any ampullary carcinoma that is not otherwise specified. Not otherwise specified. So not otherwise specified ampullary carcinomas. All you really need to know in this question is just some of the morphological presentations with this type of cancer, and just where it is found. That should be enough, and that its presentation can normally in a patient be seen as obstructive jaundice. Then moving on to the 3rd type and the last type, thank God for us, very small question in that sense, is a cholangiocarcinoma. And these have a very distinct set of presentations, different types of presentations which we need to discuss. And so the first type, I've drawn it in different colors so it's easier to follow, is an intrahepatic cholangiocarcinoma. So intrahepatic cholangiocarcinoma. And these themselves have three different types of presentations morphologically. First type is the mass forming type. And so this normally presents as a hepatic parenchymal solid mass. Diagrams to the left should aid in your understanding. The second type is the periductal infiltrating, which has infiltrations along the portal tracts, and this can thus end up presenting with bile duct strictures as well. Oops. And the third type is intraductal growth, and this growth can be polypoid or papillary in nature. And what's important to know is that the origin of these intrahepatic cholangiocarcinomas is from the stem cells that are found in the canal of herring, and this is normally seen in, like, this type of cholangiocarcinoma accounts for 10% of all cholangiocarcinomas. If we look at the tumor's cut surface as a whole, what we'll see is that these are large, non-encapsulated, usually very well demarcated, white to tan gray nodular masses. Tan gray nodular masses. So that's intrahepatic cholangiocarcinoma. Then we've got the second type right over here, which accounts for about 50 to 60% of all types of cholangiocarcinomas, and this is a perihilar cholangiocarcinoma. And so a term that is used, you may see describing these tumors, is what we call a Klatskin tumor, and this is used to define a perihilar cholangiocarcinoma that occurs at the confluence of the left and right hepatic ducts, and this usually presents with absolutely poor prognosis. Then moving on to the last type, which is a ductal cholangiocarcinoma, which is basically a cholangiocarcinoma that occurs, as the name suggests, in the common bile duct. And so together, the ductal cholangiocarcinoma and the perihilar cholangiocarcinoma make up what we call the extrahepatic cholangiocarcinomas. And what you need to know for these, as far as their morphology goes, is that these normally are firm gray nodules that are found within the bile duct, they can be diffusely infiltrative. And as far as their mass presentation goes, these are usually papillary in nature. They may be multifocal and easily friable masses. And so that is pretty much it for this question.